any questions, please write them down in the chat. And also, please try to mute your sound so that we don't interfere with the doctor as he's giving the lecture. And I think that's it. For the recording of the lecture, the technical team will record the lecture and then upload it to the website for everyone. I think that's it. So for now, I welcome you again on the training session today. You're most welcome. So I welcome Mr. Dani Mutembe, the Vice Chairman of Rwanda Health Federation, for the welcoming remarks. Thank you.
Dani, are you there? Dani?
Hello, is Mr.
Okay.
Dani?
Yes, please.
Dani Mutembe, not Dr. Dani Mutembe can start by. Dani Mutembe is not there? Okay, so let me first do the introduction of the course, and then Dani Mutembe can join in a few minutes, maybe. Yeah.
You can as well introduce the participants and the course structure, and then invite to give us the. Thank you.
Thank you very much. Oh, okay. I can first of all ask, as we discussed in a few minutes, ask everyone to unmute so that they may not interfere with the course. Yeah. Then just to remind you that we are live on YouTube, and the CTO can share the link for people who are not going to be able to join. Yeah. And I think that's it. So the course is organized for 2 hours. So we have the first part, as Ellen has said. So we're going to have the presentation from from Dr. Sugira, and then after we will be getting all the questions live via the chat box, and then at the end we are going to have time for questions and answers, and then we are going to wrap up and then have the introduction about the training session for tomorrow. So I think that's it. Yeah, and then we can just, if Dani is not yet there. Dani, are you there?
Yes, I am.
Okay, go ahead.
Hi, good afternoon, everyone, and good morning for those who are online and not in the same time zone as ours. I'd like to welcome you all to this training, organized in collaboration with Health-Edu, Rwanda Healthcare Federation. For those who don't know the Rwanda Healthcare Federation, it's a federation regrouping associations, but also organizations, government, non-governmental organizations, non-governmental organizations, non-state actors, for that matter. This includes medical doctors associations, which you have the gynecologists, the dermatologists, etc. Have the pharmacists in the private sector, and the nurses associations as well. The subject matter is COVID-19, and I really hope that you will all come out of this session with better understanding. We have a panel of great presenters. I would like to thank them for availing their time. Mine is not to take so much time, just to wish you great sessions, a great training, and great deliberations. Thank you very much. Thank you all. And I wish you a great rest of the afternoon.
Thank you so much, Vice Chairman, Rwanda Healthcare Federation, Mr. Danny Mutembe. We now welcome Mr. Jean Damascene to give us and introduce the participants that are here, and also welcome Dr. Sujira for the lecture. Thank you.
For me, I just had the small introduction. I can ask Dr. Sugira to keep going on. Thank you.
All right, let's welcome Dr. Sujira Lawrence for the lecture. I would request everyone to mute their audio so that we don't interrupt the lecture. Thank you so much. Welcome, Doctor. Hello?
Hello.
Dr. You can go on with the lecture. We are ready.
Hello, everyone.
Yes, we
So
can hear
today
you.
we look on introduction in the background on the COVID-19. I'm Dr. Sugira Lewonsi from Rwanda Trade Task Force. On our course, we look on definition, case and contact definition, risk of exposure, sign and symptoms, mode of transmission, preventive measures, comparison with others, pandemics, questions and references. Coronavirus disease 2019. It is a respiratory tract infection caused by a new strain of coronavirus that was first recognized in Wuhan, China in December 2019. It was genetically sequencing of the virus suggested that it is beta coronavirus closely linked to the SARS virus, and that is why it's called SARS-CoV-2 by International Committee of Taxonomy of Virus. It was only the definition on we have this different terminology. So we say it is a suspect case. It is a patient with any acute respiratory illness, fever, at last one sign or symptoms of respiratory disease, like a cough, shortness of breath, etc., or having been in contact with a confirmed or probable COVID-19 case or a story of travel to a resident in a location reporting confirmed cases, and can only increase the index of suspicion, but it does not exclude the possibility of a COVID-19 infection. That's what we call suspect case. We have also a probable case. A probable case, it is a presumptive positive as per lab result terminology. It is a suspect case for whom testing for the COVID-19 virus is a presumptive, or the being result of tests reported by laboratory using antigen test or PCR method. A suspect case for whom testing could not be performed for any reason. A confirmed case is a person with laboratory confirmation of COVID-19 infection using a PCR method, respectively, or clinical signs and symptoms. We have a contact. A contact
Allo? Oh, ushaka kumubwira akanimyotinga se? Ntabwo biri kwemera. Reka muhamagare. Ufite nimero se? Sawa. Allo? Njyewe ndi kuri Dr. Lawrence ubu ngubu tuvugana. Okay, reka ndebe.
Hello?
Yagarutse. Okay.
Muracyanyumva?
Iyo twakumvisha.
Hello? 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 Hello?
Allo, turi
Hello?
kukumva. Turi kukumva.
Uri kunyumva?
Yego.
N'imigisinga mu Kinyarwanda icyo bitwaye?
ntacyo.
Hari uwo bibangamiye? Hello?
Nta kibazo.
Uwo twita probable case ni presumptive positive. Ni umuntu wapimwe bakavuga ko ari umuntu uri hagati ya positive na negative. Niyo twita presumptive positive. And we have a confirmed case. A confirmed case ni umuntu watanze ikizamini cya laboratoire bakavuga yuko bagakonfirma yuko afite COVID positive. Uwo muntu niwe twita confirmed case.
So.
A contact. So we have 4 persons. The first one was suspect case, the one who have any respiratory symptoms. The second one, it is a probable case, the one which will be between positive and negative. And a third one, it is a confirmed cases, the one which laboratory test confirmed positive. And the fourth one, it is the person we call a contact. A contact of COVID-19 case is any person who had a contact with a positive COVID-19 case with a time frame ranging from 72 hours before the onset of symptoms of a case to 14 days after the onset of symptoms. Noneho twita umukontakte ni umuntu uba wahuye n'umuntu ufite ubwandu bwa COVID mu gihe kiri hagati y'amasaha 72 ugejeje ku masaha 18 ku minsi 14 uhereye igihe wa muntu yagiriye ibimenyetso. If the case has no symptoms, a contact person is defined as someone who had contact with the case within a time frame ranging from 72 hours before the sample which led to confirmation was taken to 14 days. Noneho iyo uwo muntu adafite ibimenyetso n'ubundi dufata ko ari umuntu wahuye nawe mu masaha 72 kugeza igihe bamufatiye ibipimo. So the associated risk of infection depend on the level of exposure, which will in turn determine the type of management and monitoring. So here we have a close contact with higher risk exposure. Those are people which found in red orange ring. They are any person who have one of the following: having had a protected face-to-face or one-to-one contact with a COVID-19 case within 20 meters for more than 15 minutes. Having had physical contact with a COVID-19 case, or having a protected direct contact with with infectious secretion of COVID-19 cases of a COVID-19 cases or having been in closed environment. Household members, including cleaners, security guards, live classroom meeting. Noneho hano twamaze kubona abantu bane dukunda kugira buri gihe. Uwa mbere ni umuntu twita twamenye ko ari umususpect case, wa wundi ufite ibimenyetso byo mu buhumekero igihe yaba atarapimwa covid cyangwa akaba afite umuriro. Uwa kabiri twabonye ko ari umuntu bita probable cases, ni wa muntu laboratoire yatanze kavuga ngo ntago ari positive cyangwa negative mu gihe yapimwe. Uwa gatatu twabonye ko ari umuntu bita confirmed cases, ubaye confirmé ni laboratoire yatangaje ko ari covid positive. Uwa kane twamwise umucontact, hari uwo twita closed contact, aba contact begereye cyane. Hari abantu bahuye n'abantu mu ntera iri hasi ya metero 2 mu gihe cy'iminota 15. Hakaba n'abantu bagiranye contact physique, bakoranyeho, baramukanyije, bahoberanye, baryamanye, bakoze bya bindi byose. Cyangwa se hakaba n'abandi bantu babana mu nzu, abo tubita aba closed contacts, nibo baba bari high risk of exposure. Noneho muri hospital niba ari mu bitaro, abo basangiye icyumba, abo bararana, abo bakorana, abo bose bari muri high risk exposure.
Liste ya MTN yuzuye n'abantu 74.
Having been in aircraft sitting two-seated in any direction of a COVID-19 case, traveling.
Sorry, doctor, please, Health-Edu host kids, can you unmute yourself? You're interrupting.
Hello?
Thank you. Welcome as a doctor. Unmute.
Hello?
Please unmute yourself when you're interrupting, and please, the doctor Yagaruka, we've lost him. Hello? Yes, doctor is off. Communicate with him today. We'll call Agaruka.
Yego. Sinzi ikibazo cyari kibayeho, muranyihanganira gatoya. Muri kunyumva noneho? Hello? Muri kunyumva?
Yes, turi kukumva nta kibazo.
So twari tugeze kuba abo twita aba contact twatubonye closed contact ko ari abantu bahuye n'umurwayi batikingiye. Twatubonye ko ari abantu bagiranye physical contact, twatubonye ko ari abantu babana n'umurwayi cyangwa bakorana, abo ni bitwa aba closed contact. Noneho, we have also contact with low risk of exposures, which we call the yellow ring. Those are any person who has one of the following: having have a face-to-face contact with a COVID-19 case with 2 meters for less than 50 minutes, having had face-to-face contact with a COVID-19 case with 2 meters for any duration of time while wearing any type of mask, who was in close environment with a COVID-19 case for less than 15 minutes, traveling together with a known COVID-19 case in any mode of transport while wearing protective mask, or direct care for a patient with probable or confirmed COVID disease while wearing a proper person protective equipment. Noneho abantu tuvuga ko ari aba contact with low risk of exposure ni abantu bahura n'abantu bafite COVID-19 ariko muri cya gihe bafashe intera ihagije iri hejuru ya metero 2 mu gihe kirenze iminota 10 kiri munsi y'iminota 15, cyangwa se bakaba abantu bahuye n'abo bantu ariko bambaye mask, mwaba mwagendanye cyangwa mwamwita ku barwayi wambaye imyenda yabugenewe, icyo gihe uri mu contact ariko uri kuri low risk of exposure. So we have different signs and symptoms of COVID-19. So we have the most common symptoms. Those are, we have fever, dry cough, and tiredness. Also, we have less common symptoms like ache and pains, sore throat, diarrhea, conjunctivitis, headache, loss of taste or smell, a rash of skin or discoloration of finger and toes. We have also serious symptoms like difficult breathing or shortness of breath. We have chest pain or pressure. We have loss of speech and movement. Those symptoms usually take 5 to 6 days from when someone is affected with the virus from the symptom to show. However, it can take up to 14 days. Hano turagira ibimenyetso bikunda kugaragara cyane: umuriro, inkorora, gucika intege, kubabara mu ngingo, kubabara mu muhogo, kugira diarrhea, kugira ikibazo cya conjunctivite ku maso, kubabara umutwe, kudahumurirwa nabyo bikunze kugaragara, no kugira uduheri ku ruhu. Tukagira n'ibindi bimenyetso biseriye cyane nko kudahumeka neza, kubabara mu gatuza, no kunanirwa kuvuga cyangwa kudashobora kugenda. Ariko muri rusange ibimenyetso bikunda kugaragara kuva ku munsi wa 5 kugera ku wa 6 uhereye igihe umuntu yanduriye bwa mbere, ariko bikafata kugeza ku minsi ya 14. So we have different mode of contamination. The current evidence suggests that transmission of SARS-CoV-2 occurs primarily between people through direct contact, indirect, close contact with affected people, through infected secretion such as saliva, and respiratory secretion through the respiratory droplets which are expelled when an infected person cough, sneeze, talk, and sing. Uburyo buzwi bukunda kuvugwaho cyane buzwi n'abantu bose nuko yandura igihe ugiranye contact direct, igihe uhuye n'umuntu ufite ubwo bwandu, ukandura mu gihe yaba asohoye amatembabuzi, yaba amacandwe, yaba amatembabuzi yo mu buhumekero, cyangwa se mu gihe uwo muntu akorora, yitsamura, avuga, cyangwa se aririmba. Ubwo nibwo buryo buzwi kandi bugaragara ukwandura. Also, we have airborne transmission, which is different from droplet transmission as it is referred to the presence of a microbe with droplets in the air, which are generally considered to be particular less than 5 picometer in diameter, can remain in the air for a long period of time and be transmitted to other person over a distance greater than 1 meter. Nanone bavuga ko ishobora kuba airborne transmission, ushobora kuba waciye ahantu ugahumekera ya macandwe cyangwa se amasekiresi akaba hari akaguma mu mwuka w'ahantu, haza kugira undi muntu uhagera cyangwa se undi muntu uhaciye bikahasigara,
byahasigara umuntu akaba yakwandura igihe yaba ari munsi ari ku ntera ya metero imwe ugereranyije n'aho uwo muntu yahumekeye cyangwa se yasize ayo macandwe cyangwa se ayo matembabuzi. So we have different preventive measures. So we have to clean our hands often, gukaraba intoki kenshi, use soap and water or alcohol-based hand rubs. So we have to maintain a safe distance from anyone who is coughing or sneezing. So we have to wear a mask when physical distance is not possible. Don't touch your eyes, nose, or mouth. Cover your nose and mouth with your bent elbow or tissue when you cough or sneeze. Stay home if you feel unwell or locked down. So we have current situation in Rwanda for yesterday. Yesterday we was having all total cases was 40,529 positive cases. We have 363 new cases. We have total of recovered patients, which are 9,234. We have also 192 new discharge cases free of COVID. So the active cases are 5,109. We have a total death of 186 deaths. The positivity rate was, or prevalence was 7.2%, and the case fatality rate was 1.3, and we have all the tests are 8,582, 262 tests in 24 hours. It means yesterday, all the test was 5,024 in 24 hours. It means that in 5,000, we have 363 new cases. So mu masaha 24 biragaragara yuko mu barwayi 5,000 bapimwe habone 5 n'abarwayi 24 habonetsemo abarwaye 393 n'ubu babonetsemo bafite ubwandu mu bantu 5,024. Niyo mpamvu muri positivity rate cyangwa se icyo ushobora kwita prevalence bigaragara yuko iri very high, ni 7% muri bano bantu bapimye. Biragaragara ko abantu 7 mu bantu 100 baba bafite COVID. So we have to compare with other pandemics. So the COVID has reached to more than 100 nations, including China, has caused WHO to call disease a worldwide pandemic. At the time of second week of April, these COVID-19 cases exceed 18,073,848. Other more than deaths were recorded worldwide, and the United States of America became the global epicenter of coronavirus. More than 1/3 of COVID instances are outside of China. The past pandemics that have existed in the past decade, like bird flu, swine flu, and SARS, it is hard to find out the comparison between those pandemics and this of coronavirus. Following is a guide to compare coronavirus with SARS and recent pandemic that have left.
Sorry, Doctor, you're on mute. Now go to Kumva. Wakora unmute tukakumva. Hello? Now go to Kumva, Doctor, wakora unmute tukakumva. Keys wadufasha uka-unmutinga Dr. kugira ngo tumwumve.
Yego ndabona byakunze. Mbakunyumva noneho? Hano baravuga yuko ugiranyije n'ibindi byorezo byagiye bibaho, COVID-19 niyo yagize abantu benshi icyarimwe mu gihe gitoya, bigaragara ko yaje kwimuka ikava mu Bushinwa ahubwo muri Amerika bakaba babangamiwe cyane kurusha abandi. Muri Samari ndumva aribyo bashaka kuvuga hariya. So the coronavirus with versus seasonal influenza. So influenza are seasonal flu globally every year, usually between December and February. It is impossible to determine the number of reports per year because it is not reported infectious. So no need to be recorded to municipality often passes minus do not go to a physician. List 21. So, the coronavirus na seasonal influenza. Seasonal iyo ubigeranyije usanga yo ni nka biriya bicurane bisanzwe bikunda kubaho hagati y'ukwa 12 kugeza mu kwa 2. Nabyo bitwara abantu benshi, ariko ntabwo ushobora kubona umubare w'ababirwara kubera ko abantu benshi birikiza. Usanga bishobora kwica umuntu ungana na 0.1%. So the coronavirus versus bird flu ni ibicurane by'inyoni. The several cases of bird flu has existed over the years, with the onset of the most severe in 2013 and 2016. This is usually from two separated strains. The outbreak in 2016 accounted for 1/3 of all confirmed human cases, but remain confirmed relatively to both coronavirus and other pandemics outbreak cases. After the first outbreak, about 1,253 laboratory confirmed reports of bird flu has occurred. The disease has a rate of case fatality of 20 to 40%. The percentage is very high. The blowout from individual to individual is selected, which in effect has minimized the number of related deaths. It is impossible to monitor as birds do not necessarily expire from the sickness. Ibi ni bya bicurane by'inyoni byabayeho muri 2013 byongera kuba muri 2016, nabyo byaricaga cyane, ariko byamaze igihe gitoya ugereranyije na coronavirus. Nibyo bivugwamo hariya. So the coronavirus versus the Ebola epidemics. The Ebola epidemics of 2013 was primarily centered in 10 nations, including Sierra Leone, Guinea, Liberia, had the greatest effect, but the extremely high case fatality rate of 40% has created this a significant problem from health professionals nationwide. Under 2013 and 2016, they were about 28,646 suspicious incidents and about 11 fatality other deaths are to be overlooked. Noneho uyigeranyije yo na Ebola yo yaricaga cyane kuko yo 40% by'abantu babaga banduye yarabahitanye. So the coronavirus versus the swine flu. So ni icyorezo cyabayeho mu 1916. This was deemed a pandemic again in June 2009, approximately 21 of the global population affected by this. Thankfully, the case fatality rate is substantially lower than in the last pandemic, with 0.1 to 0.5 of event ending in death. So na swine flu yabayeho mu 1918, yongera gukoroka muri 2009 ariko yo ntabwo muri kera aho yaricaga cyane ariko yo yageze kuri 21% by'abantu bose batuye isi. So the coronavirus versus severe acute respiratory syndromes was discovered in 2003 as it spread from the birds to human, resulting in about of 774 fatality. By May, they were eventually about 80,100 reports across 17 countries, with a 15 case fatality rates. The number is estimated to be closer to 90.6 as confirmed cases are accounted, with 0.9 cardiothoracic lesion for people aged 20 to 29, rising to 28 for people aged between 70 to 79. Iyi ngiyo ni acute respiratory syndromes yabagira nayo yagiraga ibimenyetso bikomeye cyane byo mu buhumekero, yabashije kwica abantu 774 icyo gihe gitangira, ariko yageze mu bihugu 17, ariko 15% by'abayirwaraga barapfaga, ariko nayo yaje kurangira. So dushobora kugomeza tukareba n'izindi. The Spanish flu pandemic was one of the greatest occurrence of recorded history. During the first year of pandemic, lifespan in the USA dropped by 12 years, with more severe killed than HIV in 24 hours. Regardless of the name, the epidemic did not necessarily arise in Spain. Wartime censoring in Germany, the United States, the United Kingdom, the France broke the news of the disease, but the Spain did not, creating the misleading perception that one more case and fatality has occurred relatively to its neighbors. This strain of H1N1 eventually affected more than 500 million men of 27 of the world population at the moment, and had deaths of between 40 to 50 millions at the end of 1920 of world people had experienced of this illness, including exceptionally high death rate for young adults aged between 20 and 40 years. In contrast to Spanish flu, the coronavirus is not so common. It's caused in fewer fatality, has higher case fatality rate, is more harmful to old age and less risky for individual aged between 20 to 40 years. Ni ukuvuga ngo Spanish flu yabayeho mu 1918 yo yatumye icyizere cyo kubaho kigabanuka ku banyamerika kigera munsi y'imyaka 12. Ntabwo nk'uko babyita ngo Spanish flu, ntabwo ari ukuvuga ko yatangiye muri Spain, muri Espagne, kubera ko icyo gihe hari mu gihe cy'intambara, ahubwo yiganje cyane muri Amerika, mu Budage no mu Bwongereza no mu Bufaransa. Bo bimanye amakuru, bituma abantu benshi batamenya ibyayo neza. Iyo ndwara rero yageze ku bantu 500,000, aribo bangana na 27% byari batuye icyo gihe, yica miliyoni hagati ya 40 kujya kuri miliyoni 50. Aho bitandukanye na coronavirus yo ibangamira cyane abantu bakuze, kandi yo ntabwo igira risk nyinshi cyane ugereranyije ku bantu bari hagati y'imyaka 20 kugeza ku myaka 40. The coronavirus versus the common cold, typically rhinovirus. Ugereranyije coronavirus na common cold, ubwo ni inkorora isanzwe cyangwa cya grippe isanzwe. The common cold is the most common illness impacted people. Typically, a person suffers from 2 to 3 colds each year, and the average kid will catch 6 to 8 during the similar time span. There are more than 200 cold-associated virus type. Infections are uncommon, and fatality are very rare, and typically arise mainly in extreme old extremely young and or immunosuppressed cases. In contrast to the most common cold, coronavirus is not so prevalent, causes more fatalities, has more cases, fatality rates, is less infectious, is less likely to impact small children. Ugereranyije na grippe, ikigaragara ni uko yo grippe ntabwo iteza ibibazo cyane yenda byo gupfa ku bantu badafite ibindi bibazo bidasanzwe, kereka nk'abantu bashaje cyane cyangwa abantu bafite ubwirinzi buri hasi. Coronavirus yo nyine yo irica kurusha grippe isanzwe. So turarangije. Ndumva abafite ibibazo bashobora kubaza cyangwa se tukagira ibyo tuganiraho haba mu Kinyarwanda haba mu Cyongereza.
Thank you so much, Doctor,
Yego.
for the lecture. We have all learned a lot from the preventive measures, signs and symptoms. So, what do you think is the cause of infection for people coming from the countryside, Changwa villages, who complain about the positive RHF result, where he or she never traveled and met other people? Hello? Ntabwo tukumva.
Hello?
Yego, ubu ngubu turakumva. Ikibazo yari abajije.
Yego.
What do you think is the cause of infection for people coming from the countryside, Changwa villages, who complain about the positive RDT result while they have never traveled or met other people?
Kuri icyo ngicyo cya mbere, coronavirus ikiza, abantu batekereza twumvaga ko nyine ari ibyo mu Bushinwa gusa bitazagera mu Rwanda, aho mu Rwanda habonekeye kesi bwa mbere ubwo mubyibuka, hari mu kwa gatatu, murabyibuka kuri 15 niho hatangajwe kesi ya mbere mu Rwanda. Hashyirwaho uburyo bwo kwirinda no kurinda abandi baturage, ariko nyuma yaho byaje kugaragara yuko yagiye yandura mu buryo butandukanye, biza kugera naho igeze mu giturage, isigara yageze muri community infection. Ubwo rero bituma nyine ugereranyije ubu ngubu niyo murebye ya mibare tubona buri munsi, mubona neza ko nta hantu na hamwe muri buri karere, mu turere twose mubona ko utwishi muri two nta hantu itari, kandi y'abantu bamuvinga barayimuvingana ku buryo bashobora kuyanduza. Bivuze ko rero abantu bo mu giturage ushobora gusanga uri pozitifu utaregeze usohoka igihugu, ariko hakaba hari ahantu hari umuntu wasohotse igihugu akayinjiza, akaba yayikwanduza, akaba yayanduza umwe, bakagenda baherekanya bikazagera n'ahandi mu giturage. Urebye n'ibyo ngibyo niko bihagaze.
Okay, thank you so much, Doctor. A comment from one of the participants. Not everyone understands Kinyarwanda, so sometimes you can use English for the explanations for the question. Okay, Dr. Tozen, I'm asking, where do we find receptors in our body for COVID-19?
What?
Where do we find receptors in our body for COVID-19?
So, usually, it is a respiratory illness. So we found it in the respiratory tracts. Niyo mpamvu ibimenyetso byinshi tugira ari byo mu nzira y'ubuhumekero.
Okay. So Daisy Umutoni asked, I did not quite understand the definition of a presumed case because you said it is between positive and negative. Please kindly clarify.
So, a presumptive case, it is a lab. It is a lab result terminology. So it is a probable case. So when you are presumptive case, it means you are neither positive, you are neither negative. So you are between the two. Bijya gusa nk'ibyo twitaga indetermine kera muri HIV ikaba irimo hagati aho kugira ngo uvuge ngo ni positive cyangwa negative, noneho ni terminology ikomoka muri labo, ariko twebwe tuyita probable cases. Ni umuntu bapimye bakabona ntabwo biri clear, it's between positive or negative. It is what we call probable case. For lab terminology, they call it presumptive positive, présumé positif en France.
Okay. The other question is there a relationship between coronavirus and gender?
And?
Gender.
Gender?
Yes.
None, ntayihari. Ntabwo njye nyizi.
Another question is, in China, they stated COVID-19 test through the anus. I would like to know the clinical reason behind.
So, iriya test ntabwo twe turayikoresha, ntabwo ndayibonaho ubumenyi bwinshi buhagije, ariko utekereje wasanga batekereza yuko ku mubiri habaye udusigarizwa twa virusi ya corona. Ntekereza ko ariyo mpamvu ashobora kwayifasha, ariko nta bumenyi buhagije mbifiteho.
Okay. The other question is, why do they always say that men are at a high risk of getting coronavirus than women?
Abagabo nibo bamuvinga cyane kurusha abagore. Guturuka muri atikita, abagabo nibo bagendagenda cyane kurusha abagore. They are moving, nibo bagenda cyane, kandi abantu bagendagenda cyane bakora movement nibo bandura cyane kurusha ababa bagumye mu rugo. So ntekereza ko ishobora ko ariyo theory iri behind.
Okay. Is it possible to get infected again with COVID-19 once you were infected the first time and got cured?
Yes. So twabonye ama cases y'abantu bagiye ba infected 1 time, 2 time, 3 times, even 4. But they clean, bakageraho bagakira, none bakongera bakandura. Inshuro nyinshi byabaye.
Okay, so far, Indi question is, I think there has been reports of ACE2 receptors in more places, including the GI tract, that could probably explain that test.
Birashoboka, ariko ntabwo ndabisomaho. Genda tuzatanga igisubizo, ariko ubu ntacyo mfite.
Are there any more questions? So far, questions in the chats, nazisomye zose, nta zindi zihari. Yeah, so this is a time for any other comments or additions. I would like to welcome Mr. Jean Damascene to comment. But before that, I'll read the last 2 questions, and then the last 3 questions, and then I will come in. Is it right that you can get infected after being vaccinated?
Yes, it is possible. But ntabwo urukingo ruzatubuza kwandura, ahubwo ruzatubuza yuko turwara cyane ngo turembe. Niyo reason iri behind.
Okay. Fabian says there is a video circulating on social media that Coca-Cola is positive on rapid test. What can you say on that?
So ibya Coca-Cola niki ntabwo ari byo, ntabwo ari byo. Umuntu ashaka kubikora kugira ngo ashake views ariko atari uburyo buri medical, kuko icyo aba agamije ni ugukora views nyine. Ashobora gufata test yari yamaze kuba positive akayikoresha, cyangwa se bakaranjinga kugira ngo bamure views bitagamije yuko ari uburyo buri medical, ariko ubundi ntabwo ari byo.
Okay. Are they doing sequencing for variants?
Abagenetisiye barabikora.
Okay. Please do us a comparison between those tests performed here. How confident do you have for rapid test?
So for the test zose zirimo zirakora, hari iya mbere iyiruta zose ni PCR irakora neza nk'uko bigaragara no ku isi yose, ni international standards, ariko rapid test those are for screening test. So for confirmation we have to do PCR sometimes, but it depends on the protocols. So now the PCR rapid test in Rwanda are the same. Ukurikije protocole dufite ivuga ko waba positive kuri PCR waba positive kuri rapid test tugukonfirma nk'umuntu ufite COVID positive, bivuze ngo byose ubu ngubu tubifata kimwe.
Okay. Are they doing sequencing in Rwanda for variants?
Ntabwo ndi sure. I'm not sure. Ntabwo ndi muri position yo gusubiza icyo kibazo. I'm not sure.
Another question from Philbert from Rwanda FDA. Doctor, can you explain the reason behind the reinfection?
What?
Can you explain the reason behind the reinfection?
Ntabwo ndyumvise neza, ntabwo ndimo kukurura ntuzi.
Reinfection.
Reinfection. Reason behind the reinfection.
Nabyumvise. Ni ukuvuga ngo ushobora kurwara, ubundi uko bigaragara bavuga ko kugeza ku minsi 14 wagombye kuba wakiyarinze utagifitemo viruses muri iyo minsi 14, ariko it depend, bishobora guterwa n'impamvu nyinshi, ariko icyo ngewe ntekereza rezo ishobora kuba yabitera bishobora guterwa n'imyitwarire. N'ubundi wakize bikagaragara yuko yabaye itarimo kugaragara kuri PCR, kuko ni chromatograph bakora, ni kavuzi bareba, babona nyine kavu yazamutse bikagaragara neza yuko ufite COVID. So igihe rero ushobora gukira, wamara gukira wahura n'umuntu urwaye ukongera nanone ukarwara, kuko n'ubundi wongeye ukandura.
Okay. So ikindi kibazo, ese ko bikomeje kugaragara ko abantu bakingiwe inshuro ebyiri bongera bakandura, ese ntibyaba bigaragaza ko urukingo rutari effective?
Iby'urukingo byo nyine
Doctor,
urukingo rushobora kuba effective, ariko ikiri effective cyane ni agapfukamunwa.
I suggest that we reserve this question for session 4. We are going to talk exclusively on vaccine. Maybe.
Okay. Hari n'umuntu uzabivugaho.
Yes.
Tuzagira training yabyo.
Yeah, on day 4.
I'm not sure. Tuzabivugaho, hari umuntu uzabivugaho.
Okay. Haracyari ibindi bibazo. Allen, go ahead.
With the questions?
Yes.
According to your experience in managing cases of COVID-19, how do you estimate outcome of patients in ICU?
Muri ICU abantu bagiye muri ICU ku isi hose buretse no mu Rwanda, abarikavaringa baba ari bake cyane, ariko bitavuze ko nta barikavaringa. Ariko iyo warembye cyane kugira ngo uve kuri ventilator ni chances ziba ziri munsi ya 1%. Ni bake cyane barikavaringa. Na hano niko bimeze nk'uko ku isi hose bimeze.
Okay. When you have dry throat, without other signs of COVID-19? Is it necessary for the COVID-19 test? I am Alphonsine Ingabire.
Ni ngombwa cyane. Ni ukuvuga ngo when you don't have any symptoms, kubera ko turamuvinga, igihe urimo kumuvinga ugenda uva mu rugo ukora akazi gasanzwe, ni ngombwa cyane kwipimisha kugira ngo umenye neza ko ufite ubwandu, ube wakwikurikirana, bitume niyo wanagira ibimenyetso utabikonfuzinga n'iby'ubundi burwayi busanzwe. Kuko sometimes umuntu ashobora kurwara akumva arababara umutwe cyangwa akagira umuriro agahita atekereza malaria kuruta uko yatekereza covid. Ubwo rero iyo umuntu amenye yuko ari free covid, bituma afata yakwirinda cyane, akirinda abandi bose kuruta uko yahagarara wenyine atipimishije.
Okay. Ikindi kibazo kiravuga ngo hari abantu bamwe batari kwemera urukingo, bavuga ko rufite izindi ngaruka zitari nziza, mwabivugaho iki ngo abantu bamare impungenge?
Izo ni speculation, ariko n'iby'inkingo ndumva hari kosi yabyo bazakora mu minsi itaha, bazavugaho cyane, ariko ni ama speculation nyine y'abantu baspekera, n'aba negativity inshuro nyinshi babikora.
From Daisy Umutoni, but after the first infection, we expect antibodies to be present to prevent against the second infection. So why reinfection?
Ubundi normally niko byagombye kugenda, ariko biza kurangira n'ubundi habaye infection. Ariko ama research aracyakomeza, hari ibintu byinshi bishobora kuba bitaramenyekana kuri covid, abantu bataravumbura, tutaramenya, ariko ko iminsi igenda iza bizagenda bimenyekana. Ariko ibyo tuzi ubu ngubu abantu bazi ni bike cyane ugereranyije n'ibishobora kuba byihishe inyuma ya covid.
Okay. Ikindi kibazo, birashoboka ko umuntu ashobora kwandura covid akayikira atabizi, mbese nta n'ibimenyetso agize?
Birashoboka cyane, binabaho inshuro nyinshi.
Indi question from Pacific. I have seen that China suspends Rwanda flights because 5 passengers tested positive. Ikindi kibazo, birashoboka ko umuntu ashobora kwandura covid. Sorry. So I can continue. I have seen that China suspends Rwanda flights because 5 passengers tested positive. Ese baba bavuye hano batabapimye neza?
Those are rumors. Ni ukuvuga ngo ibyo ngibyo nta government official wari wabivuga, yaba ari umu China cyangwa se na local authorities. Ubwo rero mu gihe Rwanda itaragira ikivugaho cyangwa se government of Rwanda igira ikibivugaho, turacyabifata nk'ibihuha until we get amakuru tukuye muri government.
Okay. For how long can a person with COVID-19 be still contagious?
14 days. Ubundi bavuga ko ku minsi 14, niyo mpamvu na quarantine, kuvuga ngo umuntu agume mu rugo, tubara iminsi 14 twavuze kuva ku munsi wa 5 kugera ku wa 6 ko umuntu ashobora gutangira kudevelopa ibimenyetso. Ariko iyo bigeze ku minsi 14 bavuga yuko umuntu aba atacyanduza.
Okay. How can you explain the use of antibiotics in the treatment of COVID-19?
Byo biri very challenging cyane, ariko
but that will be part of tomorrow as well. Tomorrow we have a session on management. Yes.
Good.
Ikindi kibazo, ese mubona umuntu wanduye COVID-19 akajya muri guma mu rugo n'umuryango we, mubona ahubwo covid itazakwirakwira cyane mu bantu benshi?
Ntabwo yakwirakwira ku bantu benshi kuko hari preventive measures, hari uburyo bwo kumurinda no kurinda abo babana. Hakaba n'uburyo bw'uko iyo tumaze kumenya yuko hari ahantu hari umuntu babana urwaye, hapimwa abo babana. Ibyo byose bituma rero itagomba gukwirakwira kuko batagiyenda.
Yes, thank you, Doctor. We have a session on contact tracing on day 3 as well. Bazabivugaho neza nabyo.
Thank you, sir.
Thank you.
Is COVID-19 dead body contagious? If yes, compared to COVID-19 active patients?
Ubu ngubu tufata nk'uwanduza.
Can you explain more?
ni ukuvuga ngo umurambo w'umuntu wazize covid impamvu bawushyingura mu buryo bwihariye bawufata nyine nk'uko umurambo ushobora kwanduza umuntu nubwo aba atagihumeka ariko yenda babifata nk'umuntu nk'uko ushobora ntabwo wemerewe kuwukoraho ntabwo wemerewe kuwumanipira utikingiye stile nubwo baba bawuteye imiti ariko tufata nk'uwanduza niyo mabwiriza.
Okay. Ese ko hari abarwara covid bakaza gupfa kandi bari barwaye izindi ndwara ubwo ni hari igihe arizo zibahitana bikitirirwa COVID-19? Ruth Mukamwiza.
No, ni ukuvuga ngo kwa muganga icyo twitikisha umuntu ni ikintu cyatumye apfa. Ushobora kuba urwaye umutima ariko warwara ibicurane bikakwica, cyangwa ukashobora kuba urwaye umutima warimo kugera mu muhanda imodoka ikakugonga. Ntabwo tuvuga ngo ntabwo wishwe n'imodoka kuko wari urwaye umutima, ngo tuvuge ngo wishwe n'umutima, ahubwo tuvuga nyine ikintu cya trigger point ni COVID-19 kuko niyo yatumye za ndwara yari asanzwe ziri kontrole yitabye Imana afite indwara ziri kontrole apfuye kubera COVID-19. ni uko ubwo buryo biba bimeze ariko bazabivugaho cyane muri management.
Okay, from Vincent Kaloti, ko bavuga ko ku bagabo batinda gukira kubera COVID-19 iba stop muri test for kandi ikaba respiratory disease bihurira hehe?
So nta article nigeze mbisoma ibivugaho, ibyo ngibyo ndumva nta makuru mbifite kuko nta article nta hantu nabisoma.
Okay, so the questions are done. Thank you so much, Doctor. I think we can get comments from Jean Damascene and others. Let me welcome Dr. Jean Damascene.
Yeah, thank you very much. Thank you very much. And I would like to, we had actually to keep going on. We had enough time to keep going on with the training. Yeah, what I can say is that we have, we had 150 people who applied to be online. Yeah, but the Zoom account that we are using, even if it's Doctor, can you remove the screen? The screen you're sharing? Can you stop sharing?
Yes.
Okay. I'm sharing the screen. Are you able to see the screen?
Yes, I see.
Yeah, we had 155 registrants, and about 58% of them are from the RHPC. We have 18% from the RMDC and NPC and Nursing Council. We have, if you go down a little bit, we have more people from the city of Kigali, about 54.8%, and other provinces are represented. And then on the question, if people will attend all sessions, the majority said yes. So almost many of you will be on the session on day 2 tomorrow. Some of people will not come back. And about the age group, we have the majority about 26 to 35. Yeah, so I think as the questions are done, we are going to share the course presentation, the course material, and we have some questions as well that has been asked, which will be used as evaluation. We are going to post it on the website of Health-Edu, which is www.healtheducate.rw, and then people will be able to log in and then can access them. Yeah, and then be able to get the certificate. And I think if we don't have other questions, I can see someone called Varinzi GMV has raised the hand. Can you please unmute Varinzi? Can the CTO remute Varinzi for the question?
Okay, thank you. So I would like to ask Dr. Sugira if the tracing is still being considered, because there is a number of positives which are tested, but I don't know if those contacts are being right now considered. That is my question.
Dr. Sugira, can you answer that question?
Yes, namwumvise. Arashaka kuvuga ngo bafite abakontakite benshi ariko ngo ntabwo barimo gukonsidererwa.
No, the number ya positive which are being tested muri iyi minsi. Ese contacts zabo ziba traced, zigakurikirana?
Yes, please. Ubu birimo birakorwa.
Yeah, and we for the course, maybe he is going to understand better on the course on day 3 on contact tracing.
Yeah, on contact tracing bazabivugaho cyane birimo birakorwa.
Okay.
Vaccine production. So I think this can be covered on day 4. It's on the vaccine. Yeah. Yes. Is there any question up here? If you are not yet registered, none of us. Dr. Harumuri kuvuga ngo ko bavuga ko ku bagabo batinda gukira kubera ko I think you answered that.
Twagishubije no kuvuga ngo ubwo tuzabireba muri treatment muri management yenda ejo tuzaba twasomye tuzareba.
Yeah.
Ariko nta theory zihari mu Rwanda zifatika zibivuga.
Okay, okay. All right. Okay, Alan. So for tomorrow, let's wind up. For tomorrow we have I was telling you that we have 157 who registered, but the account can host only 100. So for others who have linked with the YouTube, we are able to host the event live on YouTube. So the link is shared, so you can share with anyone else. So for tomorrow as well, that's how we're going to be doing that. So for the Zoom, you need to get in early, and then we can continue. For the management, we'll be having the medical management, we'll be having the intervention, the nutritional intervention, and so many other. So we are going to consider the multidisciplinary team. So there's a question from Daisy about testing. You mentioned that rapid test is also being considered as a positive test indeed. Is it possible that we could be seeing, so is it possible that we could be seeing many numbers of false positive if no CPR confirmation is done? Do you get that, doctor?
Yes, I see. So no kuvuga ubu ngubu muri protocol tugenderaho y'u Rwanda ivuga ko umuntu ubaye positive kuri rapid test akonsideranwa nk'umuntu ufite COVID positive. Ibyo kuba yagira false positive cyangwa false negative nta bushakashatsi dufite hano twakora ariko niko bimeze. Ntabwo ari ngombwa ko umuntu wakorera rapid test ikaba positive ko yongera agakorerwa PCR for confirmation. Ntabwo ari ngombwa. Protocol tugenderaho itubwira yuko rapid test ihagije ngo tuvuge ko umuntu ari COVID positive.
Okay. Yeah. So someone is asking, between lockdown and free mass immune, what is the best strategy?
So lockdown niyo nziza, niyo nziza kuko ibuza abantu nyine kugenda ngo batandura ari benshi. Ariko niyo nziza kurusha ibindi bintu byose byakorwa. Na mass testing nayo ni nziza ariko niyo ya mbere. Kuko iyo abantu batagenda ari benshi, muri cya gihe bari muri lockdown hakaba hari abakize benshi bitabaye ngombwa ko banapima.
Okay. So there is a question here. How accurate is the rapid test?
So ni ukuvuga ngo izihari izo dufite ubu ngubu twemera zirakora nta kibazo giteye, abari biragaragara iyo uri negatifu nanone iragukonfirma kuri negatifu, niyo positif kugira positif, so nta kibazo kiteye.
Okay, do we have any other question before we? Okay, no one has a hand up. All right, so we have a question. I think he was asking about the HERD immunity. What is that? Doctor, can you read in the chat?
No, let me read and check.
Okay, so there is another question here. After being tested negative after 14 days, do we need a PCR to confirm?
No, we don't need. So if you become negative for rapid test, you don't need the PCR for confirmation.
Okay. All right. Okay. So I think none se nimba rapid test ari accurate no kubera icyo usanga hari tourist areas ategeka kuba barakoze PCR.
So it is only for the protocol. Niba ni protocol cyangwa guidelines zivuga ngo abangaba turashaka ko bakora iki, niba nk'urwego mpuzamahanga bavuga ko abantu bagomba gutraveringa baba bagomba kuba bakoze PCR, nicyo gihe nyine abantu bakora PCR. So ni protocol.
All right. Okay. Okay, so I think we can call it a day. Then tomorrow, so that's the same communication that we have. For tomorrow, we are going to host 100 people here on the Zoom. So all others who are going to not be able to get connected, they can use the YouTube channel. It will be live. Yeah, and we have not been able to go and see if there are questions on YouTube. Do we have questions on YouTube? Yeah, we have. I can see someone called. Oh, that's Joseline. These days there is what we call home safe isolation, and it is not systematic to test the whole family. What do you think on new contamination? That's a question from YouTube. Doctor, do you hear me?
Yes. There you go.
Someone called Jocelyn asked that nowadays we have something called home safe isolation.
There you go.
And it is not systematic to test the whole family. What do you think on new contamination?
Ubwo ni muri management na tracing, ariko isolation no vuga ngo iyo umuntu afite protocol ukuntu ivuga yenda bazayivuga ejo muri management.
Okay.
Niyo umuntu afite ibimenyetso bikeya adafite ibimenyetso ashobora kuguma mu rugo, abandi bantu bagasabwa kujya kwipimisha ku kigo nderabuzima kibegereye. Ni systematique, ababishoboye bajyayo abahegereye.
All right. Okay, so we're going to share the course material at the end of the course with all the people who have registered to the link. So if you are here and you did not register with the link, kindly do that. Maybe I can share the link again in the Zoom chat for people to get it. And then, so see you. The training for tomorrow will start at 2 p.m. There will no longer be an introduction. So the facilitator will keep going with the management. And then we have questions in the chat like this and the questions at the end for people who will be able to raise their hands. Those one on Facebook, on YouTube will be able to ask questions as well. So thank you very much for being here with us. And thank you, Dr. Leonce, for the presentation.
You're welcome.
See you. Thank you.
Thank you.